Oh, they're on? We're live? Oh, sorry. Hi guys. Sorry about the little technical difficulty there, but that happens sometimes. Apparently we had a bad link or something like that. I was going to work in a joke about a linked sausage, but I'm going to move on. Hold on, let me see which one we got here. Which I can. Let me upsize this so I can see what's going on. All right. So today we're going to have Steve Rabedeaux with us and do the scheduling, how we're going to run this thing. We're going to have him actually start out on steroid use. Then I'm going to get into some block grafting, some lateral sinus lifts. Isaac's going to do a complete workflow on all NX. Ali's going to present something, and anything else that you guys got that you want to throw in there, we'll get it all in the mix tonight. But it's going to be a full 2 hours probably. So, Steve, you ready? Give me the thumbs up.
You bet.
All right, even better. All right, Carlos, he's ready to start. What do you have to do to share it and do this, do that? I'm going to shut this down for a second here on my end.
Perfect, Stephen.
Let me shut my audio off so I don't get over you.
All right, you all set? What happened? Are you all set?
Yes, sir.
Yes, we're set.
Okay. Well, I think that, sometimes I think we miss some of the simpler things, and Decadron is one of those things. So I got to give some credit. A couple of things is that Carlos helped me today to make sure I'm not as good with Zoom and all that as some of the rest of you. And his wizardry has saved us, time and time again. But I got to give credit to the pharmacist at the University of Iowa, Karen Baker. She was there when I was in school, and she's been there and still is there for a lot of technical information about Decadron, going clear back to 2017. If you have not had a MAT course, that's medication-assisted therapy having to do with addiction and opioid training, you have to have that to get your DEA license renewed. It's an 8-hour course. She has an excellent one that's like, I don't know, it's dirt cheap to buy it. And in there, she talks about using Decadron as for some pain management strategies. She and I talked at length about Decadron and using that in combination with NSAIDs to reduce the need for narcotic and pain medication. It reduces reduces inflammation, swelling, and postoperative pain. I'd also like to give credit to Tim Bisga. Dr. Wehrle said, hey, you might want to contact Tim. And I was like, suddenly remember that I had seen Tim talk about steroids and knew that he had a couple slides. And I asked him if I could, type those couple of slides, and he allowed me to do that. So your normal body puts out some cortisol. That's just part of, the way that we work. 15 to 25 milligrams daily, and it's released in the morning. You'll release up to 300 milligrams, 12 times that in times of stress. And chronic stress can lead to cortisol fatigue, and high sympathetic tone will do that. Chronic steroid use, like people who are taking steroids for asthma, will also experience that same thing. So that's just kind of handy to know that. So the indications for using that is to reduce postoperative pain, swelling following surgery, any difficult extraction, flap surgery, grafting, implant placement, etc. I use it routinely, all the time. Mediate inflammatory responses. Somebody's got a hot tooth that needs endo and you can't get to it. That's a great way to drop a little next to the tooth, and that'll settle that down. It's pretty wise to give a couple drops of articaine, because when you give 3 or 4 milligrams of Decadron, it'll sting a little bit, and it's a lot more nice to have that be a little bit numb. How many of you have had a sensitive crown prep requiring to get the patient numb at the time you cement it, and then that they're going to whine, and I've just learned is like, let's just dump a little Decadron next to that, and it settles down, and I don't hear from them, and I check on them, and they're fine. You can use it in as an immunosuppressive thing for a lichen planus, pemphigus, all of those type lesions, systemic lupus, rheumatoid arthritis things. Most of those times, those are topical applications, anti-inflammation for mucositis, whether that's from chemotherapy, just general oral ulcers, pain control in conjunction with NSAIDs. And that's what, we're going to focus on tonight is superior to narcotic pain control. And again, I want to give credit to Karen for that MAT series. My experience is that, I'm like the rest of you. I do general dentistry. I take out wisdom teeth. I take out other teeth. I drill holes. I put implants in people. I hurt people. That's why we use local anesthetic. I have a narcotics license, just like the rest of you. But in the past 3 years, I have prescribed two prescriptions of tramadol. Is the only opioid that I have prescribed in the past 3 years. I use a lot of NSAIDs. Tramadol for somebody that can't take NSAIDs because they got, just terrible kidney problems. But most of the time, using the steroids in combination with the NSAIDs has completely eliminated my need for narcotics. There are some off-label and outlaw uses. There were a number of people who shall remain nameless who took some of that during COVID, and I'm going to tell you, it's like it's an ace up the sleeve. So looking at the corticosteroids that are available for usage, this is a great chart, and I put a green box around the dexamethasone, which is Decadron. Here's the important thing is that it has no mineral corticoid activity. So you're managing salt and you're managing blood or water volume and raising blood pressure is not an issue with Decadron. Look at the duration and the plasma half-life. It's just the only thing else that comes close is betamethasone, and that's not as readily available as Decadron is. So here's a couple of points. Is that again, mineral corticoids regulate salt and water balance and in turn affect blood pressure. The glucocorticoids mediate inflammation, stress-related functions. And, Decadron, 5 milligrams of Decadron is equivalent to, all of these down here. A lot of times a Medrol dose pack, which is methylprednisolone, is, it's on the order of, 5 times the strength. And you're going to see that it has some other, real advantages, like right here, is that when you're taking something oral, here's the onset, here's the peak, and the duration is, a couple of days at the best. IM or submucosal, like right next to the site, like we're using it. Your onset is in the first hour, your peak is in the first hour, and your duration is 6 days. That's amazing. So here's a picture of what I use. Dexamethasone, it's 100 milligrams per 10 milliliter bottle. It's a multi-dose vial. So there's 10 milligrams in 1 ml, and then I use a little insulin syringe. And that whole syringe is 1 ml. So one full barrel of an insulin syringe is 10 milligrams, just so you get a reference. It's like here, I just did a third molar surgery and I'm going to give it right next to the site. And I just don't, it's like, well, knock on wood, but I just don't have a lot of post-operative calls or post-operative problems in the past, well, since 2017, so 3, 4, 7 years. So I want to review here. Not everybody's used to using multi-dose vials, so here's what you need to know is you pull back what you want, the amount that you want in air first in the syringe, wipe the rubber membrane of the vial with some alcohol, insert the syringe, push the air in, and then turn the vial upside down, keeping the needle in the solution, and draw out the amount that you want. After you get it out of the vial, flick the needle, push it up, make sure you get the air out of the air out of the barrel, and now you're ready to deliver submucosal dose. So here was a meta-analysis back in 2010 from the Journal of Oral Maxillofacial Surgery. Corticosteroid use decreases pain and edema significantly without the risk of infection, with minimal risk for other side effects. And a lot of oral maxillofacial surgeons in our area, if they've done IV sedation, they'll just run Decadron in the line and give it systemically, not submucosally. So here's another study. Again, this came from one of Tim's slides. They did two groups, pre-op antibiotics and NSAIDs, pre-op antibiotics, NSAIDs, and a post-op dose of dexamethasone. Group A, 66% had severe pain at 12 hours and swelling peaked at a day and a half. Group B, 8% had severe pain at 12 hours and lower swelling at every time measurement that they measured. So there are some contraindications, and you need to know what those are. And here's the absolute ones: the viral or fungal, tuberculosis, severe apnea. Notice the asterisks on the glaucoma, because this doesn't apply to methylprednisolone or dexamethasone because it doesn't have any mineralocorticoid activity, and you're not affecting blood volume and blood pressure. And then the crazy people are absolute contraindications. The relative ones, again, going down there is some GI disease. We'll talk about that in just a second. Renal difficulties, again, notice the asterisks on blood pressure, uncontrolled diabetes. These are all, kind of relative. It's like you have to mind your manners with some of those. Corticosteroid use with steroids and NSAIDs do increase your risk of having some ulcer issues, is basically what they're saying. And I've not experienced a lot of that, but it's one of those things that's listed, and we should heed that. So recommendations are: consider the administration of corticosteroid for limiting pain and swelling. Timing: about 4 milligrams of dexamethasone one day before this. This is some of their recommendations: 4 milligrams in the injection site. Some authors suggest, following that up the next day. For me, that was one of those things that is like, okay, that's all well and good, but it's actually kind of a whole bunch of hooey, because nobody's coming in the day before, nobody's coming in the day afterwards. Your opportunity is to do that right after you just did the surgery and make a judgment as to just how much you need. I typically use about 4 milligrams next to the site for a single surgery. Like if I've done an extraction and a graft, if I placed an implant, I'll use up to 10 milligrams for a full arch surgery or multiple site injections. Use a single dose at the end of the surgery. I gauge the damage that I caused and dose by experience. It's kind of a guess. I do not give that follow-up. I do not give a pre-op dose. I do not give it the next day. Nobody really wants to make those extra trips to see you. It's like, and who of us has the time? I don't know if anybody has any questions, but I just think this is a huge missed opportunity for most people.
Why don't you give the steroid before you start your procedure?
Well, I could, Isaac, but I don't, because sometimes I don't know how long the surgery is going to take, how much damage, and I may want to, I was like, okay, maybe I was going to think that this was easy and I was going to give 3 milligrams, and it was hard, and I wound up sectioning a tooth and laying a bigger flap, and now I want to give 5. And I would rather they're still numb. By the time the Decadron starts to work, the anesthetic has started to fade. It just gives me an opportunity to gauge just what kind of damage I did, I guess. To be honest.
What's that? Hey, Steve.
Yeah.
Do me a favor and check with Tim on that. I'm pretty sure to have maximum effectiveness, you want to start this before you start cutting, because I think I heard that in his lecture because I heard his lecture, God, 5 or 6 years ago.
Yeah.
And by the way, I've done nothing since because I'm that sorry as a clinician. Because I think you're exactly right about all of this. Check with him and then send that back to me, and I'll send it out to the whole group and to see if it should be pre-op before. Because I think before you start cutting, because once you start cutting, the swelling, the whole cascade starts. I think the whole point of the steroid is to get it in there before. I think, but I don't know that.
Well, that's interesting just 2 weeks ago, I was person to person with Tim in Des Moines, and I told him about that I was going to do this, and we chatted through that. And we back and forth about some of that. He didn't take a hard line on that one way or the other.
Okay, cool.
That's interesting that you say that, because and I thanked him for allowing me to use the slides, and
It's been 5 years, dude, and my brain's getting worse. I'm getting older, man.
Anybody else have any questions? Okay.
Hey, Dr. Steve, I had a quick question. That study, it said that the study was 16 milligrams. I was just wondering why you recommend 4 milligrams if that study says that they did 16 milligrams.
Those were a bunch of oral surgeons, and they run it in the line, and I'm using it IM right next to that. And I've not found that dosage. I don't need to use that high a dose. You always run the risk of putting, not anybody into necessarily a cortisol crisis, but you start to tip the balance when you get the equivalent of north of 60 to 70 milligrams of prednisone equivalent. And I will go higher when I've taken out all the teeth on an arch. But for a lot of single site surgeries, I haven't found that to be necessary. And I buy those vials. I buy 10 of those in a flat, and it's about $175. And you can cause some. You give 10 milligrams, 12 milligrams. That first night, those people they're going to be a little restless. They're not going to sleep all that well. It does have some effects that way, and try to balance that. Other questions?
If you're doing benzos, no effect, right? No.
No, you can use them in conjunction.
Gotcha.
Yeah.
I would like to be uppers and downers together.
Yep. It's one of those. It's one of those things that I just think. I think it probably for a lot of us is like it was not talked about, and it was just like, oh, you don't it's like, I don't know. There's some kind of a fear to use steroids that goes back to the 1980s in dental school, and it's like, I just had an awakening about 5, 6, 7 years ago, and it's like, why aren't we doing that? If the oral surgeons use it that often and they use it regularly, why am I not using that? And they started to use it, and it was like, this was crazy not to be using this. And then I was like, I need to tell all of you about it. Good.
You telling us.
Thank you.
Yeah, I got another little thing that I talked to Mike about. I know you kind of got crunched on time here, but this is super quick. I know a lot of you do this indirect, but this is what I do for process and locators. Just a couple of little hints. This is what I use. I just use a repair acrylic. There's some locators. The abutments are on. Here's one of the keys is I take my little Danville thing and I air braid the keeper. Then I put on the skirts, snap on the keepers. There they are. I want I want that hole. I want that relief in the denture. It can be completely passive. Use a 6 or an 8 round burr, and I cut a vent hole. I got excited and took the picture before you see the vent hole in there, but I do cut a vent hole in there. I use fiber force. We talked about that at one of the other study clubs, is reinforced denture. You can kind of see some of the mesh of the fiber force in there. Then I take powder and liquid, just in 2 Dappen dishes. And a third dish that I'm going to mix up some acrylic in. All right, so here we go. I prime the sites with the liquid and I put the mixed acrylic in the hole. Oh no, in the holes. Then I wet and bead brush around those keepers. And this is the key to getting really good adhesion and not having any voids, is I just bead brush around those. Then seat that bad boy completely. You do it. Don't trust the patient to keep it in the proper location. That's on you. So then you take it out, and some of the skirts came with it. And then you trim the flash, and I do this at the
Till I put the headphone back to talk.
Then I trim the flash. Now you have a base for the bite records, the try-in, and the final delivery of the denture. Those snap to place, and then I don't have anything that's wandering around when I take the bite. I use a lot of locators. I'm in the middle of the cornfield, guys, and I got a bunch of people who their dentition has failed, and I'm trying to give them back some function and dignity, and they're not either not financially all on X candidates, or I don't believe that their age and dexterity is such that they can take care of it. And I want something that's going to see them till they turn room temperature. And so I use a lot of this. Any questions on that?
Good.
If you're
All I
doing
got.
only one pickup, will you still do a vent hole?
It's pretty much routine. It's Isaac, right?
Yeah.
Yeah, I pretty much do that because every once in a while you'll trap air in there and you get that thing all done and you're like, crap, there's a bubble there. And it's like the vent hole just pretty much eliminates that. Yeah. But I've had really good success with that. And I've had really, spotty when I've had the lab do that. It's like, sometimes it's like the lab doesn't understand what a locator is. It's unbelievable. And finding a good removable lab in Iowa that I can work with. I finally found somebody that makes fiber force, and it's like, but I just found that I'm better off if I process those keepers myself.
Steve, have you tried that impression technique I tried showing you guys about?
Yeah, the one with the little wine glass things.
Yep. But with
Yeah.
the specific, with the tray built with the tubes around it.
One time in the lab butchered it, but that could have been just their learning curve on it.
Since I've gone to that, I haven't had one not work yet. And
Okay.
because this is just another step that used to make me nuts now. The way you're doing it is better than the way I was doing it. You're more consistent, the vent holes and this and that. That's fantastic. But I tell you that sure has made my life a hell of a lot easier. And I even then now have locators through the wax rim stage and all that because they do it at the very first pickup impression. I don't put 4 on, but I'll put 2 on. And it's just kind of nice when everything just pops right into place.
I agree. And I like the stabilized, I like having the locators at the base plate stage because it doesn't, then you just know. I like that. But I thought I'd show you this.
Hey, no, this is great, man, because there's all different ways to skin a cat out there. We all know that. And there's no one way that works every single time because there'll be a time that doesn't work. Then you got to pick it back up.
How true.
All right, brother. I appreciate you coming on and sharing that with us. I'll see you in a week.
Yes, you will. Later this week, dude. Get the right
That's
day.
what I meant. That's what I meant in 3 days or 2 days or whatever.
Friday. Now, how do I get out of here and get back to the main screen?
Carlos is going to do that. That's why we have a Carlos.
You're going to hit that purple button in the middle of your screen on the taskbar at the top, all the way at the top.
Looks like a person.
Right there. Yes, sir. I think
He's
you're
drawing.
I think you're drawing. Yeah.
Yeah, you're drawing.
How am I
There you
doing
go.
that? I don't want that.
There you go. And then you just hit stop sharing.
Okay.
You're good
See,
to go.
See, that's why I gave Carlos credit, is because he does know how to run this stuff.
There's a reason Carlos is here, by God, and it's not because I know what the hell I'm doing when it comes to this stuff.
All right, I'm gonna mute. I'm out. Thanks for the opportunity, guys.
Percent?
You're muted, right?
Al, you ready to go?
Ali Albeer,
Yep.
you ready to present? Go ahead and do
I'm
it.
ready.
Because when Isaac and I get going, we're just gonna roll.
Okay, perfect. So let me share my screen here. Okay, do you see my screen?
Yes, sir.
Okay, perfect. So this is a case that I would love to have a discussion about. It's an immediate number 8. So do we extract and place immediate implant placement, or do we do partial extraction? So this lady came in and tooth number 8 is broken, domestic violence, and it's been broken for a while. So the fractured piece is subgingival. This was today, so I didn't take a screenshot of the cross section here. But basically, the root is sitting on the labial plate. There is no labial plate. So what we're seeing here, do you see my arrow?
No.
No, sir.
Anyone? Do you see my arrow?
No.
No.
Okay. I don't know if you can
Yes,
see
yes.
it, but
Yeah, I see it. I see it. It's just a little slow.
okay. So that portion where it's not covered by blood, that's the root right there. Okay, so we don't have a lot of width here. This is the portion of the tooth that you can barely see it. I don't know, it kind of looked wonky here. I don't know if it's kind of ankylosed with the bone, but that's the root there. And so width, we have about 5.5 millimeters. And here we have about another 5.5 from the incisor foramen to the root of the lateral incisor. So the only place to place the implant would be right there. So I decided to put a 3.5 because I felt there's not enough room for 4. If I put a 3.5, that leaves me, I was thinking of probably 0.5 millimeter or just hugging the incisor foramen canal and being at least, 1.5 millimeters from the root of the lateral incisor. And I wanted to stay away from the labial socket shield that I'm going to do here. Okay, so I sectioned the tooth in half, mesiodistally, and I try to remove the palatal portion very carefully, but I felt that if I do that, I might dislodge the labial portion as well. So what I did is I just trimmed through it with a surgical burr. Here, I was working at an office where they don't have the partial extraction therapy kit, so I just used just a regular surgical burr. So I shaved all the palatal portion off, and then I started my osteotomy here. And you can see it's kind of close to the incisor foramen and as far as I can from the root of the lateral incisor. So increased the dimensions of the osteotomy. And then here I placed a 3.5 millimeter, 3.5 by 11.5. And that's the socket shield right there. Okay, that's what it looks like. Okay, and as you can see, we're close to the incisor foramen, we're close to the root of the lateral, and we're close to the labial socket shield. So any thoughts on this? Would you have done it differently? Would you extract this piece, bone graft? What I thought here is I would get more stability of that labial plate by having that small piece there versus extracting it and grafting it. I think this would be more stable long term.
Ali, how old is this case? When did you do it?
Today.
Oh, right on. And you put the pictures on and everything.
Yep.
Ali knows what he's doing when he presents.
Yeah.
It's the rest of us that are confused. That looks great, Ali.
So let's there.
There's so little attachment on that root. I'm impressed that you're able to cut out the lingual and not make the facial mobile.
Yeah, that was my concern too. That's why I just shaved it off with the surgical burr versus trying to extract it.
I think that's a hell of a good job.
Yeah.
So we'll see how this heals up. And that's all I got.
Ali, in your anterior cases, adding a connective tissue graft, do you do that very often?
No, but I'll do it if I need to.
Gotcha.
Here, I think there was enough soft tissue. Yeah, and this patient has a low smile line, but yeah, that's a good point. Adding a soft tissue graft will provide even more stability for this area.
Ali, can I ask you a question?
Yes.
The section of that facial part of that tooth is a little bit higher than your implant. Did you shave that off and then put a cover screw and bury that, or how did you handle that after you placed the implant?
So I placed the implant about 2 millimeters below the level of that tooth piece, and palatal, it's right at the level of the bone. And so this is what it looks like. So whatever small spaces that I have between the implant and the bone, I just grafted that. I did place a cover screw. So I placed a cover screw, bone grafted that area, and just sealed everything up. I didn't have a lot of like a lot of space between the implant and the bone, just a little bit. So even if I don't graft this, I think this should heal up nicely. I might be touching the tooth surface here, maybe. It's hard to tell. But I've read literature which says that with a socket shield, you can have the implant touch the tooth surface. It should just heal just fine. We'll see.
What was that?
That's funny. We'll see.
Oh,
It'll always be.
I think you're gonna get it just fine. Although Joe would be upset that you put your implant on the edge and not the flat surface. I mean, that's very sloppy, Ali. I mean, I must say, your internal
Yeah, I'm
hex is
disappointed
off.
too. You're right.
I'd get them back
You're
and I'd
right,
give that
you're
another
right.
quarter turn there, okay?
Yeah.
You won't need it. Your placement's perfect. I'm just kidding. Hey, this brings something to mind. This kind of little soft tissue thing is bothering me. It's bothering me personally that I think I could be better at it. But when I did the soft tissue surgeries in the past, it's a big production. It's expensive. Everyone's got to go down there and do it live. I'm working with Miles Madison with some company in Brazil that makes these out of this world wonderful models, because I hate working on pig heads, because the pig head does not simulate human tissue in any way, shape, or form. It's just I was coming to the point now. When I was at a lecture with Danny refused to work on it. He said, I've never worked on a pig head. I'm a retired, never having worked on a pig head. So I'm looking at these, but I'm thinking about having less expensive meetings in Dallas than if we go and work on live patients, do all that, and do a soft tissue class like that, and have him and a couple periodontists fly out here from LA and put on a little hands-on thing, and maybe even have a Zoom portion to that. We're gonna do something similar with Exocad too, with a training program here, because the live training courses are a big jump, and they're a big cost when you're placing implant stuff that you have to work on live people. I'm trying to see if I can find a middle ground here. But anyhow, that occurred to me, something just like that, a simple little graph like that. If we can work that out on models, I think that'd be cool. I'll let you know. I'm still working on it.
Yeah,
All right.
that'll be awesome.
Allie, you're good. Thank you very much for presenting. You're wonderful, and that's a cool
Yep, thank you.
case.
Thank you. I'll stop sharing.
And we will start sharing here somehow. All righty. Let me see here. You get this over here. Oh, it was taken out. Here it is. Give me 2 seconds.
No, that's on this computer, Mike.
You know what? It's all right. Oh, it's up here now. Oh, I got it. If only you guys could see behind the scenes here.
They can't.
The genius that goes on. What it takes to keep me IT savvy. I feel bad for these kids. All right, here we go. All right, so here's the beginning of my presentation. And let's see, how are we doing on time? We started about a half hour late, so. Oh, we got plenty of time. All right. I've been working on grafting because I've become disenchanted with particulate graft, and not just my own. You guys, when you leave Puebla, all your cases are 100%. Well, that's not really true. I see failures, and I see down the road, and I did some vertical grafts I was so proud of, and then 3 years later, they had all kind of died back a little bit, and it was very discouraging. So I've been going all these courses in AID and this, that, and Dave Resnick, God bless him, he presented that time the kids were down with the LSU students were with us in Mexico. I don't know if you guys saw that or not, but the thing I love about Dave's thing is he actually shows long-term follow-up, and he takes bone samples and sends them off to the lab, and he shows. And they come back with live cells versus dead cells, being, you know, the actually they've morphed over from the live patient cells from just the dead bone that you put in there. And he's like in the 94% range or something like that. But he says it has to be very, very specific. So what makes Dave's workflow technique the different? He uses vertebral bone blocks from Rocky Mountain Tissue Bank, and the difference in these things is it's a softer bone. So it sculpts very easy to the exact size and shape. And that's pretty critical, because when you, as you're going to see in these x-rays, when you're, let's just make sure you can see this. When you push these things on and you screw them in place, they fit intimately. You know, sometimes, and I know this has never happened to the rest of you, but you'll put your particulate graft in, you get all done, you sausage it in, whatever technique you're using, you pack it in there, and then you go to take the x-ray after you've already got them sutured up and all this stuff, so you're finished. And it's your final CBCT, and you'll see that the bone sometimes is dense and sometimes isn't so dense. With these grafts, it's always an intimate contact, and it always fills it out, as you'll see over and over again, as long as you do the trimming and the shaping. There's no additional trauma with these. They're associated with autogenous, which, by the way, Dave Resnick is giving a much better, much more expanded version of this. He's got 1,400 slides in his presentation. I don't know how many he's going to be able to get in there, but he's presenting at the AID meeting in Atlanta. So I'll be at that AID meeting. I'm going down on Wednesday because the entire week is a little bit long. I think it's like 5. I think you can actually go down Tuesday if you wanted to. But I'd love to see as many of you there as possible, because the AID meetings are just awesome. But he'll be there showing this again. So there's no additional trauma with the autogenous grafts where you're cutting these away. And when you do cut those away, those things aren't as malleable. And you're thinking, what's the difference? This vertebral bone is just so soft compared to other bone grafts that are out there, or autogenous grafts. So because they're softer, you can get that more intimate contact. So it really fits so well, and it takes that. Also, if you understand what this is, it's vertebral bone, so it's hard cortical bone on the outside. Imagine cutting a hole in the jaw. or you have on the mandible, where you have the hard, dense cortical bone on the outside, and then the inside is a medullary bone that's much softer. And that just, the blood just goes through just like it's through a sponge. And that hard outer layer, it really doesn't, the outer layer holds its position and doesn't resorb very much. Now you got to trim it down nice and smooth, and which is kind of cool. I think this is fun when I do these things because they sit in place. They don't run around like granular does. You get to trim them, which is something we all love as dentists, man. We're just smoothers. That's what we do. So you get smooth and you make it perfect. You grout around it with some mineralized cancellous, and then you put a pericardium membrane over it. He also added another technique since the time I first saw this, like 5 years ago, when I saw him do this. He used a cylinder-shaped burr, which scores the bone, which causes more bleeding, but also creates a little notch in there that the bone graft sits into just perfectly. So it's really easy to get these things right where you want them. He decorticates this like a mother, as you're going to see. He puts so many holes in here that it really looks like a sponge when you're done with it. There's just blood flowing through there. I just love it. And I wasn't doing that much decorticating with my grafting. I was doing some, but not this much. And he also insists use a pericardium membrane, because one of the things that does happen with these, if you use and I did it, I went down there and I used collagen, and sure as hell, it perforated. He goes, well, why'd you use a collagen? He's from Wisconsin, got this great accent. And I said, well, I didn't have the pericardium with me. He goes, well, that's not going to work that way. I mean, that's 50-50. The pericardium is much stronger and tougher, so you have less perforations and less exposure to your things, which of course is a good thing. Okay. All right, so here's the pre-op photos on this particular case that I did. I just went down here. This is what I did just last weekend. I went down there and did a couple surgeries just for fun. Oh, and you're going to notice here that the more and more I'm taking Ashraf's rule on this, I'm disrespecting the membrane. I was thinking about that with Ali's case, how nowadays I just slice that thing open, I route it out, and I put bone in there whenever I need to. I didn't have to do it in this because I did the block graft, but I did slice through it on this and the all-NX case that we did with Isaac next. All right, so here's the bone when you're looking at it. It's only god awful in one position, but it's deficient in all of them. And another way to do this would have been to graft that, but then your position's not going to be as good. It should be to graft the incisal foramen, which you still could do, but then your implant's not going to be right in the site that you want. So I went with a bone graft here, the bone block, excuse me. All right, so I start off with both these, a laser frenectomy. You got to understand, I'm going down there to Mexico and I'm seeing these cases because you're going to see the next one too. Because I don't see these in suburbia all that often. That's why I go down to Mexico, because I can have them line up surgeries. I just get to go down and just do whatever I want and then come back here, because I don't get a lot of these in Hurst, Texas. But they're great tricks to have in your bag when you do need them. So anyhow, I don't know what the soft tissue is like. So when I get down there in both these cases, they had a good frenum pull on there. So I did the laser and I tried to just skim through without cutting all the way through the tissue so I don't disrupt the blood flow. And you're going to see this flap design here, how I went across the ridge, intersulcular, and then out of the way of the smile line, and then drop some releasing incisions down there. And Dave goes through all this in his presentation. All right, so I reflect the bejesus out of there, taking some measurements. I'm showing you how thin the bone is. And I actually sliced behind this after this through the incisal foramen to get that to release a little bit more. This is that burr that I'm talking about. And all it is an acrylic burr. Meisner's got one. Meisner, every time you buy something from them, it costs like $100 a burr or something like that. It's just incredibly expensive. I think I spent $15 to get an entire kit of acrylic burrs, and half of them ended up in the lab, and this one ended up surgical for me. And it creates, I don't know if you can see this or not.
Yes, you can.
Yes, you can. Very good. This little ledge here is what I'm talking about. And over here, the next case, the other case I did, I made even more pronounced, but it sits on there very nicely. And you measure how far down to put that, excuse me, to make that ledge. The spine was kind of tough to get in the way too. So I reduced that. You can see how I've carved that out a little bit, because I wanted that to slide in there in a nice shape. I didn't want to remove it because that's good bone, but let's be honest, I don't place a hell of a lot of implants right in the midline. All right, so this is me decorticating that thing out of there. And other than where the more dense bone is right around the nasal spine, there's blood flowing through here everywhere, which is a wonderful, beautiful thing, as you know. All right, so these are the three, actually, this is one larger bone block here. I used a 20 millimeter one here and a 10 millimeter. These things are generally 5 millimeters width by 10 by 10, or 20 or 30 or 40, depending upon the width that you want. But these things are always rounded, so I don't really get more than 20. So, and often when I get the 20s, I still have to slice through them. The burrs are really kind of self-tapping. I'll make a little starter hole in the bone outside the mouth. I'll screw the screw in to the bone block, and then I'll bring it to the mouth where it's kind of dangling. So I can, the bone block in effect is holding the screw in place. Kind of like when you start, it's just like carpentry, just like when you're starting a screw into a wood before you put it in place. And when you're doing that, I found that the screwdriver takes a hell of a lot of force. So this last time I tried using the Meg torque, and it worked fantastic. If I just put my finger behind the head of it and pushed hard on that with my finger, the Meg torque worked a hell of a lot better to get out of here. So that's a lovely little product from Megagen.
Dr. Wehrle,
Yep.
it looks like on one of those you put medullary bone against and the other one you put the cortical bone against the patient.
This is actually, no, this is all cortical here. What it is I've already trimmed this one. You see how the corners are rounded here? Mm-hmm. So when I trimmed it, I trimmed this one so much. When this thing first goes in, I didn't have a photographer with me. I was having to stop and take my own pictures, and my staff down there isn't quite as good at this. Here, Isaac would have been there. He's fantastic. When this thing goes in, man, this bone's got a sharp lip to this. I mean, a sharp lip. So it sticks up. It kind of bows up in the air like this. At least, and every piece is a little bit different. This one was much more pronounced, the smaller one than the larger one. So what you do is you want this to imagine if this membrane's rolling across here later on, and it will be, and the patient's tissue is going to be across there, and you're going to have you want to smooth the bejesus out of it. That's why this looks more porous. That's a very good point. I hadn't noticed that before, but it is. But this one just had a thicker cortical plate than this one did to begin with. And this one just got smoothed a little bit more right in this corner right here. But that's it after it's been smoothed before the bone's been added. Now, unfortunately, my photography, as I said, wasn't as good. Hold on. This is 2 bone blocks. There's the 5 by 10 by 10, the 5 by 10 by 20. Soak the blocks and the pericardium in metronidazole. Dave actually used another antibiotic. What the heck did he use? Another liquid form. I'm using Flagyl because that's what I have down in Mexico, but I can't remember. And I don't generally do that with my stuff, but Dave said to do it, so I did it. So it decreases infection. I'm telling you anecdotally because I have no study to back that up. I happen to use 6 millimeter screws here. No, that's not true. These are 8 millimeter screws. That's my mistake. I said to myself afterwards, it probably would have worked better even with 6s. Watch out the 10s or the 12s. You can go out the pallet for that because, again, these blocks only start out 5 millimeters, and then you trim them down because you only want. Why do you trim these things down? Besides making them fit, and also think about the 3-dimensional shape of a ridge. The ridge is never flat like a tabletop. It's going to be skinny at one part and wider at the bottom. So this area right here is going to be maybe 4 millimeters across. Back here, it might just be 2 millimeters across. I'm not putting any bigger bone than I need because the more bone you put, the more it has to change over and the longer it's going to take and all that good stuff. So that's the other reason you trim it down. And I thought to myself, 6s might work even better, but 6s, 8s, 10s at the most. And these are Hilt-Tatum screws. Smooth the edges, like I said. And after this, I grouted all around here, and I grouted in this gap. It really was cool when it's done. Unfortunately, you're not going to see that because we didn't take a photo of it. And then I placed the membranes. This is me virtually placing the membrane here. This is what my membrane looked like when I covered it. And I sutured it right here and right here. I tucked it in, and then I sutured through there because I saw one of the cases where Dave did that. So I didn't have to tack it in. On the next case, I actually used tacks on this. And then it laid down here very nicely. And the pericardium is a nice membrane to use because it's kind of tough like PTFE, but it resorbs. So you really can't hurt it when you're moving it around the mouth. There's no, like collagen, you can tear it. Okay, so unfortunately, there I am tied up after this because I didn't take photos after that. I did want to show you the suturing that went down here because I had to push that back a little bit, and I had to use a releasing incision up here. So that took a little bit of work to get it over there. There's the continuous there. And this is a mirror shot of the other side. So this is these two over here. This is the 4 teeth there like that. These are mirror shots. The 2 teeth here. So there it is, my releasing incision back there. I also wondered later on, and I've got to ask Miles about this, if it wouldn't make more sense to make a slice across here so the papilla don't get disturbed at all, and then just make this incision a little further back in a free area like this. Because who cares if you have a gap that's at a free-ended area back here? Nobody would. And then this would just slide forward because I had to really work to get that tissue back there. And that was a big part of it is the closure. All right, so here's my before and after. Here's number 8. That's a pretty good width across there. That's that part that was so skinny. That's pretty darn good. There's the next part, number 10. And number 11. Now, I don't have follow-ups on these because that's all of 3 days old or something like that. So I have another case here. Let me stop there and ask if there's any questions. All right. Well, I'm going to do one more of these. You'll see if you come up with any. Okay. This is the next patient. And the interesting thing about this is one of those cases I was talking about where it was grafted by the Beyond Beginners with my, great instructors that all understand grafting, and they do, man. I'm not dogging on them. Heck, frustrates me. And the graft failed. So this is what the tissue looks like after she's already had 1 surgery. And I was a little leery of going in there, but the more I looked at the bone, the more I said, we can do this case. And this one does have a little bit longer follow-up, so at least I know I'm not perforating. So there it is. I've flapped it out, and I've run this one around, and I just did more of an envelope incision on this one. I didn't really do much of a release. There was a very small release on either end. Again, I decorticate the heck out of that, and if anything, I would have decorticated that even more. This is me showing how soft this stuff is to trim. You can trim it with this. Some are harder than others. This last batch I opened up, and it was really too hard for this, and I was taking off too much tissue. So I got a separating disc out, and I used a separating disc with a little bit of saline on it, and that sliced through it very nicely. Is the healing time prior to the implant placement similar to regular grafting? No, sorry. I should have said that. It's 5 months. So you're going to let these things go for 5 months. And if you watched Dave's presentation last time, and I don't unfortunately have these, and I can pop it in real quick at the end after Isaac's if we still have more time left, and I'll show you some of Dave's stuff. He has post-op things from 10 years, and he's got core samples and all that stuff. But yeah, 5 months is it. Odd number, but Dave swears by it. Okay, let me get this one again. All right. So this is I used 3 pieces here, but I actually sectioned those into 3 pieces so they could go around negotiate the bend a little better and get smoothed in. And so they'd fit in there a little bit more nicely. This, I'm using the barrel burr, the cylinder burr for the, actually to trim the bone. I actually use a high speed with a football burr. That's better, but I wish I could make that better for you. You can see this has some rounded edges and how that's raised up. Well, not when this thing gets done with it or a high speed handpiece. So I really do make it really smooth in there. All right, so there's the membrane going in. And I use tacks in this one, like I said. But tacks that high up are pretty easy to use. That's how the pericardium looks when it's laying on top of there. I worry a little bit about the edges on the, right at the edges right there and over there. So this last time I was anal, I put actually collagen over those also. But let's be honest, that's not what you're grafting over there. The graft is going to be over here. But for the other ones, I put little wings of collagen out there. Again, this is our case. I had the laser, had the frenectomy issues. I closed it up. And this is the patient 4 weeks later. So I did this one about a month ago. And the patient obviously looks like they're healing pretty good there. All right. This is a slide showing you the before and after on all these. my staff did the measurements on these. I didn't do these because I asked them to do this in Mexico. They measure too high up. That's why these numbers don't look more impressive. All these get wider as they go down. If they just go down another millimeter or two, you're not going to leave a implant right at the top like that. It's going to go down a little bit lower.
It's all about where you measure it.
That's very, very much so, especially when you do a presentation like this. I mean, this one here, you would never put the implant up there. You drop it down another millimeter, and then that's going to be about 5.5 millimeters down there. And if I didn't like that, I'd just drop it down another half millimeter, and I would just use an 8.5, and I would get to about 6 or 7 millimeters there. Okay, let me go back here. All right, so that's a couple cases, and I'm not Dave Resnick, okay? I'm fairly new into this, but I'll tell you this, I love the process a hell of a lot more than particulate. It just is, it's easier for a general dentist to understand these principles and work with it in their hands. It is for me. And his numbers are ridiculous good on this. So, all right, so let's talk about what happens down the road. So 5 months go by, and then you're gonna open this thing up, and yes, you do take the screws out because the screws are dead center. That's where your implant's going to go. And when you look at Dave's slides later on, he took core samples to this, and then he would graft it, let it heal again, and then let go another 3 months go by. And he put in there. For some of the cases, what I intend to do, because I'm not doing core sampling and all that, I'm going to take the screw out. I'm going to put a little graft in there from the facial, and then I'm going to put an implant right where it needs to be, and then bury the whole thing for 3 more months and expose it second phase surgery after that. That is my plan going forward here. Any other questions? All right. Like I said, if we have time left, I'll pull Dave's thing up, which is just immense, and I'll show you some of his stuff, in particular, some of his long-term studies and some of the numbers, and you get to see his cases all the way through with the pill and all that. I don't have that time frame, unfortunately. All right.
Mike, question.
Yes, sir.
This is Ali.
Yes, sir.
Your thoughts on RE implants in these cases before the bone graft?
I think that the RE is a fantastic implant, and I think it does have a use in these, but I'm still trying to wrap my head around conventional grafting in general. And if I use an RE and bail out that way, then I'm not sure that I'm not sure it's better. I'm not sure it's not though either, because I'm working with those too. I've got a couple of those placed in Mexico also. So I'm kind of fighting back and forth on this. I think I'll tell you this, R would be a very good use. It would be a bad use. For those of you who don't understand, let me see if this is, yeah, okay, I got the arrow going here. Let's say preoperatively something like this, where it's too narrow up here really to have an implant, the threads are going to be exposed. The RE implant, and I'll get you a picture of this later on, or Carlos, yeah, give me an RE picture, an RE implant, ARI for Megagen, and shoot it to me. Rather than me sitting here and try and draw it for you, I'll explain it. I'll get a picture of this up here. It's an implant that goes down in the medullary bone and then has a long neck, different size necks on it, 4, 6, 8 millimeters. So you can come up through a thinner area, just put a little bit of soft tissue grafter, and that particular area doesn't have threads on it. It's not polished, it's machine finished with a certain finish so that it's more tissue loving. So it can go through soft tissue and or hard tissue or insufficient hard tissue, and you're not trying to grab it for support and threads. All your support is down there at the base in the basal bone. So it works really well inside this because it's got the fatter implant down here and the thin collar up here. So I think RE would be a good solution for this, but I'm also working on grafting here and getting my grafting game better. So this is my solution to that.
My question for Ali would be where I like block grafting in theory. I don't do a lot of these. Congenitally missing laterals, right? Bulk up the bone, place your implant. Do you think RE would be a good solution for congenitally missing laterals?
Say that again.
The congenitally missing laterals. Do you think
Yeah.
REs would be a great solution for that?
I think so. Now, I think Neil Patel also has placed RE implants. Neil, do you have any thoughts?
There we go. I'm unmuted. I don't know if you guys can hear me.
We can hear you.
Yeah. So I haven't done a bunch of the RE implants, but the ones that I have done, I think they worked out really well. The block grafting side of it, I think I get your point. If someone's congenitally missing laterals, they usually have some sort of a defect on the buccal bone, and you want to kind of help resolve that with the block grafting too. So the beauty of having the RE implant when you're placing them is most of the grafting that you're using is non-resorbable grafting, and you're using that just to help fill out tissue discrepancies in the buccal and soft tissue grafting and things like that, just to make it look right. But if you can get the stability that you need from the threads, it seems like a pretty darn strong implant, but it's so new that I have no idea how it looks long term or anything. I mean, hell, the longest RE implant I have in there right now is probably 6 months in, so maybe a little bit longer than that. So, you know, I don't know yet. All I can go by is the studies that Dr. Park and his whole group has done. So I like the implant so far.
I love the concept of it too, Neil. So this is just coming under the heading of getting as many tools in my bag as I can. Because right now, I mean, I do particulate grafting just like everyone else. I mean, I've been doing that for 10 years. I'm just telling you that I'm trying to find something that gives me a more consistent answer than particulate does, because particulate is not 100% in my hands. And if I can get 80% with this instead of 50% with particulate, then I'd rather do that. And an RE is not going to work in every circumstance. And this has a graft material here, but it's interesting that Isaac brings that up. In Dave's presentation, he's got a lot of congenitally missing laterals in there where he's putting these in there. And he's got some 5 and 8 year follow-ups that are really nice looking, where it's still good looking in there. But again, I would say this comes under more of another tool in the bag. But that's a good question. I mean, whoop. We're going to try and go back here. Go ahead, Ali.
Sorry, Mike.
Yep.
But one more thing. Is there a risk that when you place an implant later on, you might separate the block?
That's why you wait 5 months. And Dave speaks about that a lot more because, again, he's done a hell of a lot more of them for a lot longer than I have. I am just a novice at this. I'm just introducing this to the group. But you would think so, except for the fact that this stuff bonds and becomes bone. That's the heck of this, is that all the other stuff that we use, and we've seen that in Mexico all the time. We go in there, we open it back up, and it sort of can adapted over or changed over into bone, and it sort of has it. And some of these things have been there 6-8 months, and they're still soft when you go in there. I've learned in Mexico, when I tell my students, I say, man, when you go into one of these, you just have no idea what you're going to find. Sometimes it's rock solid, sometimes it's not. That's why he latched onto this and ran with this. Gosh, I think his was 10 years ago. No, it was longer than that. It's all in the presentation. Because he opened it up and it was just amazing. It looks just like natural bone. We'll have time. I'll show you some of his stuff after this. It's just amazing. And if it really turns over to natural bone, then no, you're not splitting it away. That being said, I'm like Wehrle. I'm always going to shoot into the native bone as much as humanly possible because I don't trust any graft that much. And that's whether I'm using RE, a bone graft, a particulate graft, or anything else. As far as there was a question here about the cost of these things. The blocks themselves cost like $230, so you're paying like another $100 for grafting material for that section. So you can add that into the cost of the procedure pretty easily, but it's not a huge cost difference. On the CBCT here, let me go back because the other one had a better look at it. Because this one was nice and porous, so it gives more bones. So you can see how here what Ali's saying is if you put it in here, and you're going to drive the implant down here, is this going to spread this off and split this off? And my answer would be yes, if you do it too soon. When Dave's getting these results, this is one solid hunk of bone with 96% living material in there. So it's kind of like, you know, if you have a broken arm and it heals all the way, and that's not something that I've experienced in grafting yet. I've experienced that it's not that way. That's why I'm exploring this. I can tell you it's a hell of a lot fun to do, and it makes me feel better about my grafting than particulate and all that. And $5 will get you a cup of coffee at Starbucks, because I don't have the long-term data yet for this. But in Dave's hand, it works great. And he goes around. By the way, he teaches these block grafting classes all over the place. It's Dave Resnick, RESNIK. And if you look him up, he's always got a class coming up like 4 months later, and he goes around the country and does this kind of stuff. I'm trying to get him down to Puebla, but I was trying to get him down for the mission trip, but at the last second, he had a daughter getting married, so he couldn't go. Last second because he forgot about it. And then he talked to his wife, and she reminded him. All right, so lateral sinus lifts. Unless there's any other questions on that. But I'll circle back to that probably after Isaac. So let's just look at this. All right, so I've done laterals before. I've done about 20 or 30. I haven't done 200 or 300, but I've done much more of these. And they don't work 100% of the time, but they're in the 90% range. And if it does, it's infection that usually gets me or something like that. It's not that the graft itself fails. So the last time down, one of the docs was using a hinge method, like it opens like a garage door. And I'd seen that before, and I thought to myself, I never had any problem taking the membrane off. But the more I thought about it, I thought, you know what? I want to try this and see how it works in my hands. So what is this hinge method here? You weaken the bone in the exact same way. I'm using a high speed first, and then I finish with a piezo, just because I'm too impatient to use a piezo the whole time. But you can. The piezo is great. This is the primary use for a piezo to me, because the piezo will cut bone, but it won't cut tissue. Now, can you force it through the Schneiderian membrane? Sure you can. But if you just graze it or brush it or touch it, you're not going to cut into it. So then that's kind of cool. And then how I do it, and I don't even know if this is how the rest of the world does it, I tap mine in with an osteotome, because again, I've only got one speed and I'm too impatient. So I tap it very lightly, and as it starts to move, I tap it lighter, and then I just end up pushing a little bit in. The only difference is if I'm doing the conventional method, I actually peel the bone off there. I just grab it and slightly, gently pull up on it. And I've had really good results with that. I think I had one perforation out of all those numbers that I've done. I haven't had a lot of perforations, which is great because I don't want them. There are ways to manage it with PRF and amnion core and membrane and all that, but I'd like to not perforate if I can. So then you lift the whole membrane up, and I've got two of these lifts. I'm showing a hinge method, then I've got a conventional one after it. The bone of the membrane ideally swings inward and upward. And the nice thing about this is that the bone takes the Schneiderian membrane with it and kind of pulls up in more of an even fashion. So it goes up faster, easier, and safer. That's the idea. It frees the Schneiderian membrane. You pack the bone in, you place the resorbable membrane, and you close with suture. All right, so here we go. All right, so this is my patient. It's got a little area there. You can see how I left the apical portion, and it's not that I didn't weaken it. I definitely am weakening the bone up here just the same way I always do. It's just that I don't push up here. I'm tapping, instead of putting it just dead center and try to break through and then peel this off, I just put the osteotome a little further down here, and I tap it in, and it lifts this upward. All right, so this is I tell you, the Megagen's redone its Mika kit and its Milla kit. They had some cool tools in both those kits. This is from the Milla kit. They were just a really nice shape for working in the sinus. And some of the tools from the past I didn't like as much. I liked them more in the Crestal than the lateral kit. These things are just fantastic. I would highly recommend that. All right, this scoop was in there too. How cool is this little thing here? So that's how it carries bone, because we're always using something else where it can fall off. So they made a little scoop for this, and man, it's easy to fill that thing instead of just like, you know, 10 times using the big end of a molt or the periosteal elevator that you see here. You fill this thing about 2 or 3 times, and that thing fills that thing right up. It's going in, fills it up. Just packing it in there. Then I got the idea to stop and actually take a measurement to show you what kind of my hole I made. There was about 12 by 9. And then I'm putting just a regular collagen membrane. Although having used the pericardium, I wondered if the pericardium wouldn't be a better choice here. Although there's not a lot of pressure on these, unlike with bone grafting. And here I am suturing the bejeez out here. You can't really see it that well, but there was a little bit of a tear here. Unfortunately, I had that membrane underneath there. This guy really had thin tissue. So this was not an easy case from that standpoint. So that's my hinge method. So let me see, what's the next one? All right, so here's where I went from, and here's where I am too. The cool part is, and picture this. This thing swings up and it's still attached right there. So I sit there and I measure the distance across and how far back I went, this, that, because I didn't want it to hit as I was going up. But if you're measuring this is about, we measured that at 10, 12 millimeters. So coming across here, you got a roof that's already 10, 12 millimeters. So that makes it real easy to pack into this. And it was. I mean, I got a little bit of opacity there, but other than that, I mean, that's going to turn out very nice. And obviously, I didn't have a hell of a lot to begin with. Okay. All right. So what was my upside of this? I'll tell you what. Let me go to the conventional one, and then we'll talk about both of them together. All right. So here's a conventional. This is a much bigger area, but there's some decent bone here, so I'm really going to go back here, and there's not a great clearance. I'm going to do reduction crowns. Why am I doing 3? Because the guy's got wisdom teeth and occlusion. All right, so here we go. I use the piezo to finish this off. I'm going around there. I'm peeling this up out of there. I didn't show it that well as far as the peeling. Usually I love showing that little chip of bone when it comes off, but there goes, the bone's off. And you see the membrane underneath here. So you go in there with just like a crestal, and you just go around and around, and then you start pushing, and you have a feel. You know from your x-ray where the bottom, the floor of the sinus is, so you start pushing that way, pushing to the anterior, pushing the walls, and you know how far you're going. You start picking it up. You just have to be a lot more gentle with it. So once I got it picked up and I could see it falling down actually, and I could see it separated up in here, then I did my osteotomies, because in this case I had enough bone. I need 4 millimeters of bone to do this, and I had anywhere from 4 to 6 depending upon which one we're talking about. Use some decent size 4 5s or 5s in there. That's my bones packed down the side. Pretty good placement as far as the angulation, all that goes. And then closed it up. There's my before and after. So here's my lift like this, and which is pretty good considering I made a smaller hole. As I looked at this and I prepared this, I thought to myself, why the hell did I make such a small hole? Because you can make it any size you want, and I really should have made that one more oblong. I should have made it a little bit longer to the distal, but as you can see, I did get it back there. It does tend to go to the distal more easily than the mesial, for me in my hands anyways. All right, so like I said, this one had a little bit more bone up front. This is just, you'd have to go back to this. That's just the front half of the, if you imagine an implant going in here, the front half's in decent bone, the back half's in air, this one's in air, and this one's in air, other than the bone here, the bone here, the bone here. That's not where I needed it, unfortunately, so since I did the lateral, I didn't shoot for that. If I was doing this without a lateral, and I often cheat like this in private practice when I was first starting out, I would have scraped this one right by here, scraped this one right in here, and I would have done a bridge across here, and I wouldn't have worried so much about my placement. I'm trying to grow beyond that. All right, so again, this is just the front part of that one. And there's the implant there. There's 3 millimeters. And I think that one, I think this was 10, this ain't 5. I think this is a 10 back here. Same thing. And then the rest of this is just bone pushed up around there. All right, so what was the big difference between these two? Because I did both of these relatively recently within the last year, is that the one with the little hinge was a hell of a lot faster. Now, I'm a test study of one. but it took me like 45 minutes. Other than suturing at the end, I think the whole thing, start to finish, after the patient was numb, was 1 hour. That's pretty fast for me for a lateral because I don't do a ton of these in suburbia. And it sure was a lot easier, and it was a lot less nerve wracking because whenever you're pushing on this membrane, the more you push on the membrane, the more you think you're going to tear it. So it was kind of nice having that bone just flip that up and carry that up with it. It was really nice. That's my take on this. Now, if I'll answer any questions, or if someone else has more experience in this, they can feel free to chime in. But kind of like the block grafting, I'm just kind of introducing you to this technique because I haven't done a ton of these with the hinge.
Yes.
We have a guest contestant here. Art Henniger decided to stop by and see the magic, such as it is. He's appalled at this point, but he still has a question. Yes, Art.
I mean, obviously from your X-ray, you place the implants there in the basically loose material. I mean, is that your common practice, or I thought we let these things sit 6 months?
No, not at all. Ziv Mazur is a guy that lectures internationally on these things, and Ziv's one of the lecturers on sinus lifts. That's his baby. And he swears in any bone, any place, anywhere, that he's always going to place an implant every single time. I think the guy's been smoking too much cabbage there. I'm not going to put it in like 1 millimeter bone like we started with. The rule is, as long as you have some stability with it, 4 millimeters is for me, the benchmark. And that's what I've heard from most lecturers out there, is if you have less than that, you aren't going to do it. Now, with, as you know, with Megagen, we got the better threads, better this, but they do get weaker at the top. So the one thing different too about with the sinus lift like this, anytime in the sinus, I don't bury these as deep as I do other implants. Like in the mandible, I might go down 2 millimeters. Well, if you only have 4 millimeters and the top thread kind of sucks on any ridge, you're not going to bury it 4 millimeters unless you want to finish that lateral off by going to get that implant out of the sinus. Mm-hmm. So I tend to put these about just 1 millimeter beneath the bone, which is pretty much, that counteracts or accounts for the 1 millimeter of thread that's not really worth a lot, the top of it. Any other questions from the people that are not in the room? Neil, you still there?
I'm here.
How many laterals do you do in suburbia?
I don't do a whole lot. I kind of get actually a little bit more creative on the Crestle approach. Like I literally have one coming up on Thursday morning where I have 2 millimeters on one side of the distal aspect where the implant's going to go, and on the mesial side there's going to be 4 millimeters. And I'm going to do a Crestle approach and just use PRF as my grafting material to push up the membrane. I put a couple layers of PRF in there and then put the implant right behind it.
Cool. Yeah, I use that technique too. If I'm in Mexico and they're doing the PRF for me, or I'm here at Isaac's doing it for me, because my blood drawing abilities still suck. I'm going to go down for a weekend phlebotomy fest. That's my next trip I'm doing down there. My daughter is a master phlebotomist, and that's going to be a long weekend, a father-daughter weekend of stabbing our staff down there. But I put a layer of bone because of that, because I'm not as good. But I do that similar technique exactly like you're talking about there. I try and find some way to get around it, but sometimes you can't. And so of these that I'm counting this 20 or 30, I would say 2/3 of those have been in Mexico, at least, where I go down there and practice, because we have patients who have worse situations. They've been missing teeth for a lot longer. They have no bone back there. So yeah, I don't do a lot of those in suburbia either. But you know, when you need them, you need them.
Neil, on using PRF only sinus lifts.
Yep.
I mean, I've seen that before. Turnover, great. Get bone all the way around.
Yeah, I mean, knock on wood, I haven't had too many complications literally at all doing it that way. As long as I don't have a large tear of the membrane, but even if I have some sort of tear of the membrane too, I mean, the PRF is designed to help plug that and seal that anyway. Bill, there's a guy on Dental Town, Bill Schaefer, if I remember right. I mean, that's his go-to method on doing sinus lifts. And the first time I read that, I thought it was crazy. I instant messaged him quite a bit, and he sent me case after case and just little instructions on how he does it. I was kind of sold on it, so I've been using that as my initial go-to route of doing a sinus lift if I can. I mean, obviously there's different routes. Sometimes I'll use particulate graft and everything too, but I like to not put particulate in there if I can.
I agree with you. So he'll take CBCTs 2 years later, and we'll have bone up to the apex of your implant, or will it always be about the same level?
You know, I'll have it to the apex of the implant, and what I'm more surprised with is I actually get some decent amount of bone, you know, on the buccolingual aspect of the implant too. I thought I would just get it just around the implant. Surprisingly enough, I get more than I thought I would. I mean, all I'm looking for is just getting the whole entire implant covered in bone, but I usually get a little bit more too, but it's not a significant amount like you would get from a lateral. A lateral, I mean, you got every aspect of that implant 2 millimeters plus all around the implant. I usually won't get that doing it this method.
When I was in dental school, I had a teacher tell me that you can put dog shit in the sinus and it'll turn to bone.
Yeah, yeah, and that's kind of the theory on this, is that if you
Yeah.
could put something that's very biocompatible with the patient, you're not going to get any kind of foreign body response. I get the patient on an antibiotic 2 to 3 days before, so when you do the PRF, I'm actually introducing an antibiotic into the system then too.
It blows my mind that it doesn't like resorb back down and stay soft tissue. Like, I think that's cool. But that's just my story, and I want to start doing it that way too. So thank you for helping me sell it.
Yeah, yeah, no worries, man.
When I saw his lecture, the guy that's the PRF genius, I want to say it's Henry Pitch, it's been got 8 years of this. He was putting up PRF up there, and he was doing incredible stuff. Anyone else before we get done? Isaac's next presentation. All right, that's you ready to go?
Yep.
Take this out. Shut that off.
You got to keep yours on. Yeah. You were just hearing the computer from there. All right, 3, 2, 1, we're back on. All right.
You can just take over.
I got both mics. All right. So this is our last full arch case we just did. We just delivered it on Friday, so that's good. So it's the most recent case. I call this presentation Plan for Success because that's what we're getting better at, is planning our full arch cases from the beginning and then having a good result at the end. So I was kind of brainstorming yesterday and thinking about what can cause a failure of on-X treatment. So obviously if your implants fail, your case fails, but how do you solve that? You add more implants. They won't all fail, right? So you do 6, not 4. If you have a non-passive restoration, well, there's lots of different ways to get a passive restoration. These ways, there's photogrammetry, there's the elite oral scanner, you can do splinted impressions. There's lots of ways to skin that cat. So just do one of them. Inadequate restorative space. Well, what causes that? Well, improper planning. So just do some proper planning and you won't have that. A transition line show. That'd be a failure in my mind. And what causes that? Well, improper planning. And then a non-hygienic prosthetic design. Well, what causes a non-hygienic prosthetic design? Again, improper planning. So my point was that of all the ways that I could think of, an excessive opening of the vertical and an intolerable amount, so like lip incontinence, something like that. And what would result in that? Well, improper planning. So of every way that I could think of a full arch case failing, barring like every normal way, I'd say most of them could be solved or alleviated by adequate planning before the surgery. So this was Bob. He's 78 years old. He's got extensive decay on the upper dentition. He has a partial, but he can't wear it because he's a gagger, real bad. So he hates wearing it, so he doesn't want to wear it. I wouldn't want to wear it either. So what did we need to figure out before we started surgery? We needed to know how much bone erection to do. I wanted to make sure I knew where the correct midline was. I wanted to establish my incisal edge position. That's really important prosthetically because, as we all know, you figure out your incisal edge position and you work your way backwards, and that's how you should plan every full mouth restoration in my mind. And then figure out an appropriate amount of bite opening. And if you knew all those things, we would be able to have a pretty successful full arch surgery, right? So how do you figure out your necessary bone reduction? Well, use the 3 millimeter rule. Let me get this out of here. So you measure the gingival level relation to the Duchenne smile. So this is Mr. Bob's Duchenne smile. It's actually a little bit less than his Duchenne. He had trouble holding it that high, but it's almost his Duchenne smile. You add 3 millimeters to whatever amount of gingiva he shows, and this equals your bone reduction. So you use my little perio probe. So you measure all these little locations, and so this is about 5 millimeters of this papilla. Is about 4 to 5 millimeters of this papilla, 4 to 5, and so 5 millimeters of gingiva show plus 3, 8 millimeters of bone reduction. Easy, right? This is important that this is for FP3 type rule. So if you're just trying to do an FP3 with a nice flat ridge, fake gingiva, all those things, because you could go in here and make this FP1. You always could and try to save all your bone, but I don't think it's worth it in this situation. This was an FP3 case in our office, and I'm proud of it. I stand by my choice. Midline. Well, how do you get your midline? Well, I like to take a nice photo, square dead on with the patient's face. Now, getting an assistant to take a square dead on photo is actually harder than I thought it would be. A lot of times patients like to kind of tip their head back and smile or whatever, and getting an assistant to really get that square dead on can be kind of tricky sometimes, which is one reason why I like facial scanning, because it's easier to take a facial scan consistently than it is to take a really nice square on photo. Once I see my photo that's dead on, I'll draw my midline and then just find a spot in his current maxillary dentition that is consequent with his midline, and I'll just remember that. And so that when I do my design, I'll put that design midline at the same position, whatever point I chose, right? That's how you establish a midline. And then proper incisal ledge position. As we know that your lips kind of determine where your incisal edge should be. So at repose, based on your age, you should show X number of millimeters of incisal edge. So if you're a young woman, you show 3 to 4 millimeters of incisal edge. If you're a 78-year-old man, you probably show 0. So Bob shows 0 millimeters of incisal edge, and that's probably appropriate for him. I measured up. He ended up being, I think it was like 2 or 3 millimeters above the lip. So I figured I could add a few millimeters of incisal edge and improve aesthetics, right? All right, now you have to determine the appropriate amount to open the patient, right? We like to use our leaf gauge, our VDO gauge, and a putty that we reline twice. So you use this VDO gauge, you measure from the orbit to the corner of the mouth, and then you flip it around and you measure from the below the nose to the chin. And that should be about the same when using this VDO gauge. When I'm doing this, I always make sure that the lips are still competent. At the time, like maybe they have a really short lip and they couldn't close their lips at this height, but most people can. It's not usually an issue. And then once I do that, I determine how many leaves from my leaf gauge I can put in between their jaws. After I do that, I do my first round of putty. I just bring it up in the anterior, so it's just a nice positive stop for them, and I keep the leaf gauge in there so that they can bite on the leaf gauge, and the putty can set up. And then I'll do a second round of putty in the posterior, so I'll have them rebite on the anterior putty, push some putty in the backside, and I'll let that set up. And then I'll practice with them, making sure that they're still in their hinge position, they're still biting in the same spot. Then I will reline the bottom with light body, and then I'll reline the top with light body. So that you're seeing the blue is lab putty and the yellow is light body. There's my camera. Yeah. So I'm looking at my own computer, not looking at you guys. Sorry about that. So that's what I like to do. It's really quick to do these mush bites, and they're not really that hard as long as you can get them in a good hinge position. I do these on patients that speak Spanish, and I don't speak very good Spanish, and I don't think it gets a lot harder than that. Some of the patients down in Mexico, so I think usually you can get it done with the patients here. I like to grab a facial scan. I think as far as all the new tech that they're selling in this world, facial scans are the least important piece of tech to purchase. But it's easier to take a good facial scan than it is to take a really good photo. So if you're trying to train your assistants on something, I like to do that. When you're doing your facial scanning, you do 4 scans, usually a retracted scan. And then I like to have my facial scans at all 4 positions, to do Shane's smile, the natural smile, and then the repose. So this is an example of his repose, and then this is the retracted. You'll notice I do my retracted in all of my facial scans with the putty in the mouth, because I want their jaws to be at the position I'm going to restore them at, and that helps me relate my design. Okay, so that we just got all the data we needed, right? Appropriate amount of opening, appropriate midline, appropriate inside the ledge position, appropriate bone reduction. We got all the data collected. Sweet. Here's our records. Or here's our just pre-op photos. You see, he told me when I first met him, he goes, "The dentist I used to go to, he was pretty good. He did a good job up here." And he was really proud of the aesthetic dentist that he went to previously that gave him this beautiful bridge, which I thought was pretty funny. So there's that. Bite. That's amazing. I mean, he's got real bad decay here, but a little bit broken tooth and a little bit of decay. But really, I mean, he's gonna have some bridges in the bottom, and he's gonna have a full mouth to chew on, like he hasn't had in years. So then you do your wax up, right? You take all your data, you put it together, and you do your wax up. I was gonna show you at this point how to. How to get rid of this? There we go. So here's this CAD file, an ExoCAD, right? So you have your face scans here. Let's just look to the repose or whatever. I like to add in these lines while I'm designing, so that I can like establish where my teeth should go, and then I'll just put my stuff there. You have your wax up. I throw my wax up in there, and you just kind of throw. You have your upper jaw, your lower jaw, your face scans, and you just throw a wax up in there, and you just kind of remember all your stuff. Now, one thing that people I don't think quite understand is when you scan your putty 360, right? And this is why it's important to reline your putty. Is that if you look at this guy's bite that I have, you think he actually keeps his mouth in this position when I try to do a bite scan? No, he bites all the way down super deep into down here. But if I bring in my putty and my putty's relined with light body, it's accurate enough to align the internal of this putty to my intraoral scans, right? If I didn't have the reline wash with light body, it wouldn't be accurate enough to have a consistent alignment there. And so I wouldn't be able to use this putty as my bite alignment scan, right? So that's why it's important you align it. And that's why you take your putty, right? So now we're back into it. Okay. Gotcha. All right, so you made your wax up. Sweet. That's just me showing you about the lab putty and stuff like that, right? Get your waxes going. All right, now it's gonna play a game. If you were shown this CBCT and you were said, hey, plan out an implant in this position, which one do you think you guys would lean towards?
Anyone? Somebody venture a guess. A, B, or C? C being the one in yellow.
I would say B.
Yeah. I mean, yeah, that's what I'd probably lean towards too, honestly. I mean, none of these are perfect, but because I did my initial planning and I realized that I have to remove 8 millimeters of bone from this site in this location, what I do in my planning software is I throw a 2 millimeter abutment, digital abutment on top of my implant, or 10 millimeter, pardon me, a 10 millimeter digital abutment. And I place that 10 millimeter digital abutment about equal to the bone. And I know I have to have my implant apical to that 10 millimeters. Well, I said 8 millimeters of bone reduction. Why do I have a 10 millimeter abutment? Well, that's easy. You want to put your implants at least 2 millimeters subosseous on full arch full arch implants or full arch cases, okay? Especially when you're using MUAs. Anytime you're going to use an MUA, you want your implant at least 2.5 millimeter or at least 2 millimeters below the bone. Why is that? Because it allows you to use a 3.5 millimeter MUA, which is a better MUA to use versus a shorter one. And anytime you can, use a longer 3.5 millimeter MUA. So use a shorter implant and use a longer MUA. It's gonna save you in the long term. I'll talk about that a little bit later. So yeah, so like 5 millimeters, 3 millimeter rule, things like that. Just remember that. I measured 5 millimeters. We got it. Oh, that's why the answer is A. So we got to take off more bone, so you can't place this implant because you got to take off all this bone. So you got to place this short one that's super deep in the base of the bone. Great. All right, and then that's how you plan depth, and then you got to plan your angulation. Well, how do you plan your angulation? Well, you take that wax that you had in your exocad and you pull it into your CBCT software, and then you can have this little outline of your wax up, and then you can angle your implants to come out the areas you want to, and you can angle all of them so that they're all coming out palatal to your teeth, which is ideal, right? Sweet. Now, here's the MUAs, right? We want to use a 3.5 millimeter straight MUA anytime we can. And we want the restorative platform of the MUA to end up 1.5 millimeters above the bone. So that's the way you think about it surgically is you place all your implants in a position that will allow you to put a 3.5 millimeter MUA on it, and you'll have your restorative platform 1.5 millimeters above the bone, because you can't be playing with tissue and doing tissue math while you're doing the surgery, but you can look at the bone and measure 1.5 millimeters. Why do you want to do that? Well, for one, everybody's had a little bit of dieback over time, right? And what you can't have is a high watered MUA. You want all your MUAs to be equigingival or a little bit below gingiva. So let's say at 3 months, you just say you did a 1.5 millimeter MUA, and it was perfect in relation to the gingiva after your surgery. Well, 3 months later, you had some tissue dieback. You can't go shorter, right? But if you did a 3.5, you can go shorter down. You can go to a 2.5 or a 1.5 and still have a great prosthesis. The other advantage of putting your restorative platform 1.5 millimeters just above the bone is that you can suture your tissue back together, and your tissue is usually about 3 millimeters thick, right? So when I design my prosthesis, I'm just going to ignore whatever tissue scan you give me. I'm going to make a 1.5 millimeter chimney on it. And chimneys are really nice to have on your prosthesis because they make the next day delivery a lot easier. Rather than trying to push a flat prosthesis onto tissue, if you have this little chimney coming down, they slide right in with no anesthesia every single time. So if I know you as a surgeon are doing your surgery right, and I can expect you to put an MUA with a restorative platform, like I said, 1.5 millimeters above the bone, I as a designer can have a much easier time designing your prosthesis, and you can have a much easier time delivering it. So
Isaac, go back for 1 second for
Yeah.
people that haven't done it all next. Why is that so important that we keep the profile low on that for the MUA coming out of the tissue? What do I care if it's up above the tissue? It's easier to grab.
Well, let's talk about that. Let me pull up this exocad file here. So this is the prosthesis the temporary prosthesis we had, and these are the chimneys I'm talking about, right? Your implants. Not that. Sorry. So these are in theory are.
Analogs.
What am I looking for? No, you're right. Okay. This is our scan by scan, but think of these are as good as implant analogs. Just think of them as implant analogs, right? So these are our implants right here. And this is our restorative platform. If this restorative platform was higher, especially in the anterior, right, and it was higher, and let's say it showed, worse than that, your MUA showed in your smile, well, you have to cover that up with porcelain, right? Well, now your MUA is up here. You have to extend your porcelain up to cover that. Now you have a flange. Now you have one of those affixed with flange denture. Affixed with flange denture, you end up with something like this. Case photo. This is under bottleneck design. This is what you get with affixed with flange. You get that. This is you get a bunch of inflammation, you get your implant exposed, you get, where do I have another better one? Of his upper was worse. Yeah, so you see his restorative platform was right here, but they extended the flange up apical to it, so this is completely non-cleansable. So if your MUA is above the tissue, by nature, you're either going to have a huge food trap because you have to make your prosthesis high watered, or you're going to have an uncleansable area because you had to extend your prosthesis to your tissue, and you have this little pier going on. So it's bad and bad both ways. So you just got to get your MUAs at the level of the gingiva. Using a taller MUA allows you to pivot 3 months into surgery and give you a better result there. So that's why it's important to have your MUAs at that position.
This is what we've learned because we've been inheriting cases from people saying, hey, can you fix this? And the number one factor that we've seen is poor prosthetic design. And then when we go back to try and fix it, is some of them you can just lower the MUA down a little bit because they had the wrong size MUA on there. But most of them, there's nothing you can do about it. So we have to hit this happy medium to make it better for the patient. And there's things that Isaac has developed to do that. But this is what we're seeing over and over again is poor planning to leaving this to guys. So this is something that's so great that Megagen is pushing on all of us with zero bone loss contest is bury the implant, bury the implant, bury the implant. So that tube trick that he came up with was just fantastic. We sat here and planned out every one of these to put them deeper in there. So the minimum we had was a 3.5, and if I went in there and I didn't like the tissue, didn't like this, didn't like, I could bury it down another millimeter and use a 4.5 if it's a straight. You can't do that with the angle ones, but the straight ones you can.
Well, you can do a 4.5 with an angled one.
Oh, that's right. Yeah.
You can't go too short. That's the advantage of using straights, not angled. At least with Megagen, is that every time you go up an angle, you'll lose a shorter MUA, right? So the 30-degree angle, you only have a 3.5 and a 4.5 option. At the 17-degree, you only have a 2.5, 3.5, and 4.5 option. You don't have that 1.5. So the straights can go shorter than the angled ones can. So if you're going to do a 30-degree, sink it 1 more millimeter if you can. That way you do your 4.5, and then if you have to pivot, you can go down to a 3.5 maybe. I don't know, something like that, right? So that's the story there. That's that. That's your ideal MUA. That's why you want to have that. It makes your life easier, and it makes your temporaries to final go easier. So think about that during your surgeries. Then you do your surgery. I only have one slide here because this is the easy part. We can all put screws in the bone and get decent stability. We're good at that stuff. And then you do your post-op records. I ended up doing the Insta for this. What do you need? Well, you need to know implant location, tissue contour, and you need some kind of piece that connects the pre-op records to the post-op records, right? If we want to talk about OptiSplint after this, we can talk about OptiSplint. But for Instarisa technique, they use an artificial reference screw or fiducial screw, right? So you get this before you start surgery. You scan the teeth and the fiducial. Obviously, the teeth can go back to the pre-op. Then you catch your fiducial and your implant scan, right? Because these are the implant positions. Then your fiducial can be aligned to your fiducial. And then you take an impression, or you make an impression of the tissue with these little abutments on it. Well, these little abutments, there's a digital file that you get. You see that this top part is the identical shape to these little abutments. So that once I tell the software, hey, implant here, implant here, implant here, implant here, this gets generated, and I can align the jaw or the tissue to the rest of my pre-op records. So that's what you need. You need an implant location, a tissue contour, and a piece that connects pre-op to post-op. That's all you need, right? There's lots of different ways to do this. Then you connect your wax up, which is where you had before surgery, to your implants, and you'll see that ours looks, dang near identical. Dr. Wehrle put a few implants a little to the buckle, but we made it happen. And that was the day of delivery, right? That was last Friday. Obviously a little too light. I got a little more pink to the gums, but he's happy, which we like that. And he did not complain about the crossbite in the posterior, which is good. It's half a joke. And that's how he looks when he smiles. That's day of delivery here. We're gonna see him in a week. We obviously we did really loose suturing, just a couple horizontal mattresses. That's an important thing. That's another way avoiding this drama of where did my picture go? No keratinized tissue on the buckle. Just do a inside your KG right down the middle, and then leave a big hunk of it on the buckle of it, and then leave a really loose suture. Don't suture it tight together, and you're gonna have more KG growth rather than having a bunch of mucogingival defects everywhere, which we'd like to avoid if we could. That's that. Here's him smiling. And this is what he used to look like, and this is what he looks like now. Great. Last thing is, how do you go from interims to finals, right? Well, these are the records that you get. I always retake the facial scans. So I take my facial scans 1. Scan 2 is this bottom one. I scan the top, bottom, and bite with the temporary in the mouth, okay? Then I'll make an impression or a scan of the tissue, and you'll need some kind of piece inside the tissue that will help you align it to the rest of your record. So talk to your designer about what you're putting in there, and he'll have some kind of a solution for that. I'll then retake the implant position data, whether it be with Scandar, OptiSplint, intraoral elite scanner, or photogrammetry, whatever you do, I don't care. And then you'll scan the prosthesis out of the mouth. But when you do that, you have to screw in something on the backside. So these are the Instarexa intaglio attachments. You can use a different shape as well. Usually whatever this is and whatever this is related somehow. And you can talk to your designer about that. One thing I like to use is I'll use just those MegaGen MUA analogs, right? The ones that come in the MUA kits. Those can also work for this. You just screw those in and scan at 360, and they can serve the same purpose, only they just cost less. So I like those. And lastly, when you go into final, don't forget we placed big MUAs for a reason, so that at this stage, when things shrink up, we can go smaller if we need to. So take a look at all your MUAs and make sure all your MUAs are at the level of tissue or a little bit lower. And if they're not, go ahead and take them out and then put a shorter one in there so that you can keep a hygienic prosthesis. That's basically it. I had another extra case that showed going from temps to finals, but I think that photo does a pretty good job. Unless somebody has specific questions, I'll show it to you.
No questions.
Carlos,
Yes, sir.
you have my hard drive?
Yes, sir. Here you go.
Tell you that when I listened to these lectures before, the reason I didn't have any questions because I didn't understand what the hell he was talking about half the time. And I'm just being honest. It's been fantastic getting to work with Isaac, and I get to watch him go through these over and over again. And he's teaching me very slowly, and he's taught the other staff that has more time even faster. What all these parts need and how they mesh together, and it's just fantastic planning these out now together. So we sit here, and there's no more surprises anymore. Surgery. I was always able enough at surgery to MacGyver stuff together, but that's really not the way you need to be doing it. His way with planning it out works a hell of a lot better. Trying to find here.
Yes, Ellie.
Great presentation as always. Can you repeat that part where you said you create an incision around the MUA and leave it without suturing to allow the keratin tissue to build up?
Exactly right. So the rule is, whatever is. So you got the flap, right? And you got 2 pieces of tissue. If you leave that open and you don't suture it back together, whatever will grow in the middle will be made of whatever these edges are made of, right? So if let's say I have 4
Right.
millimeters of KG right on the ridge, and I cut right down the middle of the KG, and then I do my surgery, and I leave those super flapped open. Keratinized gingiva will grow in between those flaps. So what you really should avoid,
Right.
as much as possible, is primary closure.
So let's say, one of the photos that you showed, one of the MUAs, there was mucosa
Yes.
movable the buckle,
Mm.
and of course on the
Mhm.
palate side you have keratinized tissue.
Yes.
How would you solve a problem like that? Because once you create an incision, you'll have the mucosa part start building in.
So you
Yeah,
can obviously
that
do a free gingival graft. One idea that I
Right.
like, and I haven't done this yet, but I got a periodontist friend that recommends it. If you just kind of cut some tissue from the palate, pick it up, and then just kind of it's just a reflective pedicle flap, right?
Right.
And then you just pull it over the buccal and suture it down, and then leave a open spot on the palatal. The palatal will fill in, and then the KG will stay on the buccal there.
I see. Yep. It's
Yeah.
like you slide it to the buccal side. Okay.
Exactly. It's just a
And
it's a
it's a
rotated pedicle
partial
flap.
thickness.
Yeah. So you could do a rotated pedicle, or it'd just be talking about a flap design at that point. How do you want to flap it and move it?
Yeah. Okay. Cool. Cool. Thanks.
And this guy was, like Dr. Wehrle said, you see that all his MUAs are tall because his implants weren't deep enough. We couldn't go any shorter. They just don't make the part. So you just try to design it better, and I have pictures of, because he's about to go to finals. His finals are in the oven right now, actually. I have to glaze those, but so this is the new design, and this is me without cleaning it. All I did was unscrew it, and this was 3 months. This was 3 months of him wearing this, no cleaning, just unscrew it. And it looked that good. And I was like, heck yeah.
This has been a real win for us. I'll tell you the strange upside to patients like this. They've had such horrible restorations and such a horrible situation that you only have to get a little bit better. You're right. You can do a free gingival graft and do this. This guy's happy just to have something that's not packing food underneath there that he's not in pain with. And this is like the 3rd or 4th case like this that we've done where we've saved these, and we haven't had to do any advanced perio. Again, that perio is why I'm working on this study model thing with that, because it keeps coming back to that. And there's all sorts of cool tricks. What do you do when you've got that little stripe of tissue that you have the little old lady that's got just 2 millimeters of keratized tissue is all they have? Well, I keep trying to find an easy way around this, and Miles keeps telling me the only way is to actually get in there and graft it. So I want to learn grafting from him and work with you guys on this. We've got like another 8-10 minutes left. So did you download it in here?
Yeah.
Okay, cool. He's hooking me up with you want to do it over there?
Yeah. You're gonna share your screen.
Give me 8 more minutes here and I'll show you some of Dave's stuff with the bone studies afterwards.
Got it.
It's under Puerto Rico bone graft. Because the course was in Puerto Rico. Puerto bone. That's it. It's down a ways.
Here you go.
All right, give me a second here. If you can see this in the corner, he's got 1,300 slides on this. I'm gonna get you past. He breaks it down, block grafting, this kind versus that kind. Let me see here. Trying to find one with the congenital missing laterals here, because there's a lot of those in here, actually.
I think I'm gonna buy one. I think those are all.
Here we go.
missing.
There's so many in here. All right, so here we go. Slideshow from the current slide. All right, he just lists all his supplies he used in here, but it's basically just exactly, he uses Tatum implants also. All right, so they got a bony defect. Cleans it out of there. You got that recession. You can see the x-ray next to it. And look at how he decorticates that. I mean, he's just a decorticating son of a gun. There's his bone, his membrane, and he's got this little lip on it, right? Sorry, I was using my finger. That doesn't help you any. He's got the little lip on it right here because he sutures that part in on the palatal. So then it's tacked down there and then it folds over. So he puts in the bone block and then he smooths the bejesus out of it and grouts around it. Look how intimately that attaches. And that's every time with these things. When you sculpt them right and it's so soft it compresses in there and lasts a little bit, it just works really well. Sutures up. He's all about tension free. He's got different flap designs further on here. He shows this. So the lone stitch lapel is the one that's the only he's using to hold that together. And there's his suture over there that holds the pericardium in place. Okay, and you'll see that the defect is gone now outside there. So there's 5 months. Look at that difference. That's the kind of thing that you're talking about, and that shows up on photographs because there's different lighting. Look at how well that bone is in there. It's just all the way connected. There is no real place to split it free. Very little resorption.
Mike,
yes,
yeah,
sir.
that is pretty impressive. Mike, I missed that part. Where do you get that graft from?
It's Rocky
blocks.
Mountain tissue graft, and it bank should be tissue bank. And if you if you go to AID, everyone there just swears by their bone blocks because they've all learned from Dave, and everybody there uses Rocky Mountain. I've never been to a lecture yet where they use a bone block that isn't Rocky Mountain. Carlos is going to put that into the portal here, and it's going to pop up here in a second, so you guys can have that information.
Okay, thank you.
Sure. I tell you this, it's a damn fun graft. I mean, look at this as a general dentist. How fun is it to trim this corner, smooth that down, grout that in, because you're not fighting this. With particulate, you're always fighting it, at least I am. Maybe with sticky bone, it's better, but then you got to know PRF to do that. Well, how many of you, honestly, are placing PRF out there? I've told you myself my challenges with it. It's not the managing it; it's taking the blood. So instead I hire staff members to do it because I suck at phlebotomy, and I've taken the course and all that. It's not one of my gifts. So look at that defect before and after. Takes the screw out, and I think this is one where he does the bone punch. All right, so here's what he does. He's done a bone biopsy. He asks the patient's permission always. He takes it out, puts particulate in, closes it back up, and he sends that off to a lab in Minnesota, I think. And what he's showing you here is 98% is new vital bone. Only 2% residual. That's nuts, man. 98% is part of their human body after 5 months. And all the guys he's talking to that he sent these grafts to says, you know, how the hell are you doing this? And you got to know this guy. He's your typical Midwestern guy. He's as rock solid, honest, straightforward a dude as you're going to meet. He's not one of those guys that's up there lecturing. He just handed me this 1300 hard drive and said, here, you can have it. It's all about spreading the information, which is what the guys, the rock solid guys at the, there's his name right there, by the way, in case you want to write that down and look him up. He's just a dude, man. And so I have no doubt about his results. Zero. Now, whether or not I can reproduce them, that's what I'm trying to find out. But this really isn't that technique sensitive. I think I'll be able to. Puts the implant in there, closes up around it. Nice and fat out there. Tissue looks so much better after the graft. Tatum implant. It's restoring it. This is old school restorations, but puts it in the lab. Just different ways to restore things. Trims it down. Puts it in. I didn't like this one, neither did he, because the it comes out a little bit fat, like final crown does.
Isn't the temporary?
The final crown's this way too, unfortunately.
Blame the orthodontist.
That's right. Except for his wife's the orthodontist.
Ah, crap.
Yeah, be sleeping on the sofa. All right, I'll show you this one real quick and then we're done. Let's see, is this, no, this is a sinus graft. It was the one before this that I really liked. He's got so many, it just takes me a second to find them. No, that wasn't her. She was posterior. No, Randy was at posterior too. There's a one of those exact ones that he was talking about here. That shows his flap design, by the way, for this particular case. He does intracircular around there, and then just did one release and does a sort of triangle shaped flap. And he's got little slides like this that tell you all this. And this is the lecture that he gives, that he'll be giving in Atlanta. Let me go back to, this is the one. This is a lateral we were talking about. He's got so many of these cases, it's just ridiculous. Okay, there you go. Number 7, congenitally missing. This will be the last one we do. All right, so he's got the defect. Looks almost too small to have a tooth in there, to be honest. Shows you it up there. That bone's god awful right there. But it's a lot better if you can put a graft in there. Look at that, how he wants to place the implant and what he has to do, because you're talking about whether we put in native bone or not. This guy's so ballsy, he actually puts it, it's almost like bicortical stabilization. It's native here and it's native there, but when he's done, all this is in graft. Decorticates the heck out of it. Again, just carves that in there nicely. I mean, that's just so much fun to do. And there's the particular grouted around there that we're talking about here. Just grouted around there. And that the block acts as a tending procedure. So unlike other granular where it's all relying on itself, it can get mashed down and moved so easily. I think that's the problem with particulate, which it doesn't happen to a bone graft, a block like this, and a little bit about the edges. It's got the biggest tent in the world. It's got this huge block of bone in the center. Again, same technique. He just sutures it on the palatal, flips it over to the buccal, puts it in there as it's sutured up. There's the bone block. Tissue's looking good. Let's take another tissue sample, and it's going to show you 94% new and vital. That's just nutso to me, man. Because I'm telling you, from somebody who watches the end result of the grafting in Puebla, and we got good guys doing good work down there and using good materials and all that, but it's just, I just don't think it works as well as this, at least not in his hands. Now, what I'm trying to do is see if I can teach it in my hands so I can teach it to all of you, because that's always the thing is, can somebody else reproduce that? Look at that, because remember where that bone was. That thing is, damn, 85% of that implant's in graft material. And I'm thinking, damn, that bone's a little thin, man. I don't know. And there it is. And when you do his slides, he literally writes out every word when you listen to his slides, which makes it kind of a beating when you're watching his presentation. But it's great if I was going slower, for you to sit here and just read every single word, because he's basically telling you exactly what he's thinking. This almost like having it recorded over. All right. 5.5 weeks later, the tissue's starting to heal around there. He puts a little vent hole. I think this is a great idea. Now, I do this with all of mine because all mine are screw-mentable, but even on his ones that are to be cemented, he calls it the Resnick cement vent hole because it keeps the cement from pushing downward. So even if you're going to have a cemented restoration where it's not going to line up because the angulation is coming out the facial, something like that, still put a vent hole here because it keeps that cement from pushing apically. Just like Steve was talking about with the resin.
On top of that, you can use a custom zirconia abutment in the anterior to make your margins at a good spot to make it more cleansable. And also the zirconia is not going to have that graying of the gingiva like you with a titanium abutment.
Mm-hmm. All right, so there's his final restoration. He's got, we're already at the end here, so I'm going to stop because that's 9:30. We started a half hour late. We're finished half hour late. But he's got hundreds of these things, and he's got a bunch of them where they came back like 10 years later because they lost another tooth. So he gets to show you x-rays of the first one, and it's not a hell of a lot different, man, 8-10 years later. And he's only got 1,300 slides, so you can imagine how many cases he has of these and how in-depth he goes in this. That's what intrigued me to this. And that's why I'm taking a dive into this again and see how these come out. So every time I go down to Puebla, I'm doing a block graft. I get down a day early because I always work with beginners, so I don't get to play with this cool stuff like Ashi does. So I'm doing a block graft and a lateral graft every single time I'm down there now, just to practice these things. And I'm going to share these results over time and see how it goes. But again, Dave will be at the AID in Atlanta if you guys want to go. Any questions on this? All righty, it's 9:30, it's past your bedtime. Levi, Sean, I'm really impressed you students could stay up this late. Actually, I'm more impressed that I could stay up this late.